Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, in continuation with the previous module, we are going to see about the polycystic ovarian syndrome. So in the previous module, we discussed about the major important points about the polycystic ovarian syndrome, including what are the important features of polycystic syndrome have been dealt. Right? So in this module, we will be dealing with the salient important features of polycystic syndrome in the terms of criteria for polycystic syndrome and how is the management being done, what are the presenting complaints the patient is going to come to you, and how are we going to manage them according to the symptoms with which they present to us, and certain important POIQs as well. Okay, yes. So let's start with the topic without any delay. Okay, yes. So, when talking about PCOS or PCOD, the one criteria which has to strike your mind is this criteria which is called as the Rotterdam's criteria. It is called as the Rotterdam's criteria. So, the most important thing is that you need to remember the three important features of this criteria. Right? So, what are the three important features? The first feature is that increased androgen levels. So we have discussed that in patients of PCOS, there is increase in androgen levels in them. Is that right? Yes, because the LH is increased. So the LH acts on the thicker cells of the ovaries and produce increased amount of androgens. So this increased amount of androgens can be depicted clinically as hirsutism, which is the growth of the coarse hair which is similar to the male pattern, or it can be manifested biochemically as hyperandrogenemia, where the levels of androgens are increased, where it is somewhere around 70 to 200 nanograms, right? Yes, so this is about the increased androgen level. So clinically it is hirsutism, biochemically it is hyperandrogenemia. The second feature is ovulatory dysfunction. We all know that since the levels of luteinizing hormone, that is LH, is increased throughout the menstrual cycle, because of absence of LH surge, there is no ovulation in patients of PCOS. Right? We all know that for ovulation to happen, LH surge needs to happen about 24 to 36 hours before the ovulation. Only if LH surge is going to happen, then ovulation will happen, and then the mature ovum will released, and along with that the corpus luteum is going to be released. So the major function of corpus luteum is to produce the progesterone. So the main hormone which is going to be predominant in the second half of the menstrual cycle is progesterone, and this progesterone will be maximum by around day 22 of the menstrual cycle, and suddenly this progesterone is going to undergo withdrawal because of degeneration of the corpus luteum. So once this progesterone is going to withdraw suddenly, because of this progesterone withdrawal, there is going to be lack of support to the uterine endometrium, and the patient is going to menstruate. But in patients of PCOS, since the LH is high throughout the menstrual cycle, because of absence of LH surge, there is no ovulation. What is called as no ovulation? It is called as anovulation. So because of anovulation, the patient will complain to you either of oligomenorrhea, which is infrequent cycles, or amenorrhea, which is absence of menstruation. No ovulation, no menstrual cycle. So the two important features, one is increased androgen levels, second is ovulatory dysfunction. The third is the most important one, because the third criteria of the Rotterdam's criteria is dependent upon the ultrasound feature. So in ultrasound, you have to see polycystic ovaries. So Rotterdam's criteria tells us that in ultrasound, if you're going to see polycystic ovaries which fulfills the following three criteria, what are those? There has to be more than equal to 12 follicles in the ovary, right? If you're going to do the ultrasound of ovary in a patient of PCOS, that ovary has to have about more than equal to 12 follicles, and these 12 follicles should be around 2 to 9 millimeter in size, which is roughly less than 1 centimeter. So more than 12 follicles in the ovary, which should be around 2 to 9 millimeter in size, and it can be present either in a single ovary or it can be present in both the ovaries of the female as well. We all know that there are two ovaries in female, so it can be present either in a single ovary or it can be present in both the ovaries. So what is the feature? More than equal to 12 follicles of size 2 to 9 millimeter, either in one single ovary or in both the ovaries of the female. Either it has to be between 2 to 9 millimeter in size, or it has to be more than 10 cc in volume. So the first feature is more than equal to 12 follicles. The second feature is either it should be between 2 to 9 millimeter in size, or the volume of the ovary has to be more than 10 cc. If in ultrasound you're going to see this kind of polycystic ovaries which fulfills the criteria of Rotterdam's, any two out of these three criteria, the three criteria were increase in androgen levels, ovulatory dysfunction, and polycystic ovaries on ultrasound, if any two of these three Rotterdam's criteria is going to be positive in a patient of PCOS, then the provisional diagnosis of PCOS is actually met. So Rotterdam's criteria helps us to come to a provisional diagnosis of PCOS, but not a confirmatory diagnosis. With this criteria, only a provisional diagnosis of PCOS can be made. So in order to come to the arrival of provisional diagnosis of PCOS, any two out of the three Rotterdam's criteria has to be positive in that female. Is that clear? So this is all about Rotterdam's criteria. Right? Okay. So since we are discussing about the PCOS in ultrasound, let me show the most important ultrasound feature in females of PCOS. That is necklace appearance of ovaries in patients of PCOS. What is necklace? So necklace is something which we wear, right? So it will be like this. Some designs will be present in the necklace. So now you can see here that this appearance is similar to the necklace, which has an appearance like this. So this ovaries are compared to the necklace appearance, right? So this is called as necklace appearance of the ovaries in patients of PCOS. So what you can see here is that multiple follicles are present, right? Multiple follicles are present, and they are present in the periphery of the ovary. So multiple ovarian follicles which are arranged in the periphery of the ovary, right? And these multiple follicles are actually immature follicles which are arrested in growth because of increase in androgen levels in that female. So multiple immature ovarian follicles which are arranged in the periphery of the ovary is all about the PCOS appearance in ultrasound. But you may ask me that whether there should be multiple ovaries only in the periphery of the ovary to come to an arrival of PCOS. No, it is not like that. It can be present in the center as well. As you can see here, the ovarian follicles are present in the center of the ovary, and they are also situated in the periphery of the ovary. So it is not like that it has to be situated only in the periphery of the ovary. It can be situated anywhere, but since it is situated in the periphery of the ovary, it is called as the necklace appearance of the ovaries in PCOS patients. Clear? Yes. And the most important point to remember here is that it is not very particular that if you are going to do ultrasound in a patient of PCOS, right, the ovaries has to be polycystic in nature is not necessary. The ovaries may be normal in a patient of PCOS. The ovaries may be polycystic in appearance in a patient of PCOS in ultrasound. But at the same time, in a patient of PCOS, on ultrasound, the ovaries may be normal as well. So it is not very particular that the ovaries has to be polycystic in nature. No, it is not like that. The ovaries can be normal in a patient of PCOS also. Is that clear? Yes. So now we have met about the Rotterdam's criteria, the three important features. The only important thing that I have to tell you here is that there is a controversy arriving here, that whether it is more than equal to 12 follicles or it is 20 follicles. See, as per the Rotterdam's criteria, it is only 12 follicles, more than equal to 12 follicles as per Rotterdam's criteria. But if you take into consideration the American or the European guidelines, they tell that they have updated their guidelines from 12 follicles to 20 follicles. So American and European guidelines tells us 20 follicles has to be present in order to come to a provisional diagnosis of PCOS. But the Rotterdam's criteria tells only 12 ovarian follicles. Is that clear? Yes. So now you tell me, what are the three important criteria which are taken under Rotterdam's: increased androgen levels, ovulatory dysfunction, and polycystic appearing ovaries on ultrasound. So what are the criteria which are not taken into consideration in Rotterdam's criteria? So the necklace appearance on ultrasound, which I discussed just before, it is not a particular criteria which has to be taken into consideration. So what are the features which are not taken into consideration? necklace appearance of the ovaries on ultrasound, insulin resistance in patients of PCOS, obesity in patients of PCOS, menometrorrhagia because of increase in E1 in obese female. In obese female, androgens get converted into estrogen in the adipose tissue with the help of the enzyme aromatase. So in the obese females, the level of estrone E1 is high. Since E1 is high, the patient may complain of menometrorrhagia as well. So menometrorrhagia, insulin resistance and obesity are features of polycystic ovarian syndrome, but they are not taken into consideration for the criteria. So necklace appearance on ultrasound, insulin resistance, obesity, menometrorrhagia and increase in LH levels, they are not taken into consideration for the criteria in polycystic ovarian syndrome, right? Okay. So having discussed about the most important particulars of PCOS in terms of what is the actual pathology happening there and what are the features, how a provisional diagnosis is actually met and what is the most important criteria, now we are coming to the management of PCOS. So before discussing about the management, the most important rule is that always please remember, in patients of PCOS, treat the presenting complaints of the patient. Please don't overtreat the patient. See, in a patient of typhoid, you may start the patient on 2 or 3 dual antibiotics because it is okay to overtreat the patient rather than undertreating the patient in a case of typhoid fever. But in patients of PCOS, you just treat the presenting complaint. Whatever complaint the patient is coming to you, you treat that complaint and send the patient back. So treat the presenting complaint of the patient after confirming the diagnosis of PCOS is the most important rule you need to take into consideration, right? That is the first rule. The second rule is that lifestyle modification has to be advised to all patients of PCOS. Irrespective of the management you are going to administer, you have to add lifestyle modification to that female. Why? Because is that even minimal weight reduction in patients of PCOS can have drastic symptomatic improvement. The insulin resistance might get improved in patients if they are going to lose about 5 to 10% of their weight, right? So lifestyle modification in terms of exercise and dietary modification, etc., has to be advised to the patient, to all the patients of PCOS, irrespective of the complaints. Clear? Only 2 rules. First rule, treat the presenting complaint. Second rule, lifestyle modification to all the patients of PCOS. Okay, so for an easier understanding, I have divided this management into various cases. So we're going to have a practical approach now where a female will be coming to you with one such particular complaint and you are going to treat that complaint, right? So let's get inside the clinic. Okay, so now you are the doctor, you are sitting in your clinic and a female is complaining. A 20-year-old female, she is complaining of menstrual irregularity to you. So what is the menstrual irregularity which has been observed in a patient of PCOS? It is oligomenorrhea and amenorrhea. So if the patient is going to complain to you of oligomenorrhea or amenorrhea, you just check the age of the female. If the age of the female is coming under the reproductive age group, you have to follow up it with urine pregnancy test. Because I always used to tell this one single point to all my students, that is, if a patient is going to come to you with complaints of heavy menstrual bleeding, any kind of menstrual complaint like oligomenorrhea, menorrhagia or amenorrhea, absence of menstruation, if the female is coming under reproductive age group, the next important test you have to do is urine pregnancy test, because the most common cause of secondary amenorrhea is pregnancy. So do the urine pregnancy test, rule out the pregnancy and then follow up with the next process. So you have done the UPT, the UPT comes out to be negative. And then you have done the series of tests which you need to do, such as the thyroid function test, and every single test you have sent. And after sending all these tests, the report comes that there is increase in LH levels, right? The FSH level is normal, LH level is increased, and estrogen, if she is a thin female, it is going to be normal. So after doing all the investigations, you come to a diagnosis that she is the case of PCOS. So now we have confirmed the diagnosis of PCOS. So now what are you supposed to do? Now, what am I supposed to do is that this patient is complaining to me of only menstrual irregularity. The complaint she is having is menstrual irregularity. So, as a clinician, as a doctor, my duty is to treat only that complaint in patients of PCOS, right? So, I have to start her on oral contraceptive pills. you give OCPs to that female. So the major function of OCP is to regularize the cycle. So if you're going to give oral combined pills, the cycle of that female is going to get regularized. So this patient will be taking the OCPs for about the set days and she is going to stop. So once she is going to take the OCPs, she is going to have amenorrhea, and once she stops because of progesterone withdrawal, she is going to have a period. So similarly, she is going to take the tablets for some particular days and then she is going to stop. So if she is going to take the tablet, she is going to have amenorrhea. Once she stops because of progesterone withdrawal, she is going to menstruate. So in the similar fashion which happens in every single month, her cycle is going to get regularized. So her cycle will get regularized to about 28 to 30 days once she is going to have her cycles. So the drug of choice for treatment of menstrual irregularity is oral contraceptive pills. So you give OCPs along with lifestyle modification, right? So this is case 1. Now case 2. Case 2 is where a 20-year-old female is complaining of hirsutism. What is hirsutism? We have discussed that. Growth of coarse hair in male pattern, right? The patient is complaining of hirsutism to you. Now, my role is to treat that hirsutism. So the treatment of hirsutism in patients of PCOS is to give the drug of choice, that is oral contraceptive pills. You give oral contraceptive pills for the next 6 months and see the improvement. If there is no improvement even after 6 months of giving oral contraceptive pills, then you have to start anti-androgens in that female after trying OCPs for a period of about 6 months. So after 6 months of trying oral contraceptive pills, if there is no improvement in hirsutism, you start anti-androgens, because hirsutism happens because of increased androgen levels. So start anti-androgens, that is spironolactone. You administer spironolactone along with oral contraceptive pills, right? So the treatment for hirsutism is OCPs for 6 months. Check the improvement. If there is no improvement even after 6 months of OCPs, start anti-androgen, that is spironolactone. Along with that, you have to advise lifestyle modification. This is all about case 2. Now, case 3. A 20-year-old female is complaining of pigmented velvety skin around the nape of the neck. So pigmented velvety skin around the nape of the neck is called as acanthosis nigricans. Acanthosis nigricans. What is acanthosis nigricans? Acanthosis nigricans is a feature of insulin resistance. So what is the treatment of choice for insulin resistance in patients of PCOS? The drug of choice is metformin. Metformin is a biguanide which is actually administered to patients of type 2 diabetes mellitus. But here metformin is used because metformin improves the insulin sensitivity in that patients, right? So since it improves the insulin sensitivity, the drug of choice for treatment of insulin resistance in patients of PCOS is metformin along with lifestyle modification. Is that clear? Okay. Now case 4. A 26-year-old female complains of inability to conceive despite 1 year of unprotected intercourse with her partner, and she is a known case of polycystic ovarian syndrome. So inability to conceive despite 1 year of unprotected intercourse is a complaint of infertility, because the definition of infertility itself, inability to conceive even after having 1 year of unprotected sexual intercourse with her partner. So she is a case of infertility and she is a known case of PCOS. Now, infertility and PCOS is interlinked to each other. Why? Because is that in patients of PCOS, since the follicles are arrested because of increased androgen levels, there is no ovulation. There is anovulation in patients of PCOS. Since there is no ovulation, there is no release of mature ovum. Since there is no release of mature ovum, there is no fertilization and no conception. So the major problem here is anovulation. So I always tell that anovulation is the most easily treatable form of infertility. So that as a clinician, your duty is to induce the ovulation. Anovulation is present in patients of PCOS. So your duty is to do ovulation. How are you going to induce ovulation in patients of PCOS? You have to administer certain drugs which induce the ovulation in patients of PCOS. So the drug of choice for inducing ovulation in patients of PCOS is letrozole. But if you ask me what is the drug of choice for treating anovulation overall, The drug of choice for treating anovulation in general female complaining of infertility is clomiphene citrate. But in patients of PCOS, the drug of choice for inducing ovulation is letrozole. Okay, so letrozole. Followed by letrozole, you can use clomiphene citrate. If letrozole cannot be used in that female, you can use clomiphene citrate. Right? So these drugs are going to induce the ovulation. The female is going to ovulate and eventually she is going to conceive. And also please remember there is chances of abortion in patients of PCOS even after they conceive because of decrease in progesterone level in patients of PCOS. Right? Yes. Now, what is the most common side effect of clomiphene citrate? The most common side effect of clomiphene citrate is hot flashes. Please remember the most common side effect of clomiphene citrate is hot flashes, and this question has been asked in Mackler solve as well. So if you want to solve those questions, please go to the post section in YouTube Mackler handle and you can solve the MCQs as well. In that I have asked about which is the most common side effect of using clomiphene citrate. It is hot flashes. And what is the side effect of letrozole? Most common side effect is headache. The most common side effect of using letrozole is headache, followed by hot flashes. Right? Okay. So the drug of choice for inducing ovulation in patients of PCOS is actually letrozole. If letrozole is not available, you can use clomiphene citrate. But letrozole and clomiphene citrate cannot be administered, or if they have failed. What is the second line management? The second line management is giving HMG injection. What is HMG? Human menopausal gonadotropin. So this human menopausal gonadotropin is actually prepared from the urine of the menopausal female. So in patients of menopause, from the urine of the menopausal female, this HMG is actually prepared. So we are going to administer this injection HMG to patients who are complaining of infertility in PCOS. Multiple follicles will start to grow. Right? Multiple follicles will start to grow. And once the multiple follicles will start to grow, as an ovulation trigger, you have to give injection human chorionic gonadotropin. See, first you give HMG. Okay? When you give HMG, multiple follicles will start to grow. Multiple follicles will start to grow. And then as an ovulation trigger, for a trigger, you're going to give injection HCG. You gave HMG initially, now you're going to give injection HCG as an ovulation trigger. But there is a criteria to give injection HCG. It is that since there are multiple follicles growing, the amount of estrogen estradiol should be between 500 to 1500 picogram per ml. Only if the amount of estrogen is between 500 to 1500 picogram per ml, you can give injection HCG as an ovulation trigger. Right? Only if the estrogen is between 500 to 1500 picogram per ml, you need to give ovulation trigger, that is injection HCG. Once you give injection HCG as an ovulation trigger, the ovum is going to be matured and multiple matured ovum is going to be released from the ovary. And once it is getting released, if it is fertilized very soon, it will result in conception. Right? Fertilization is going to happen and conception is going to happen. Since the chances of multiple mature ovum is releasing from the ovary, therefore this multiple mature ovum can get fertilized during the act of coitus. After the act of coitus, all these multiple mature ovums can get fertilized. So the chances of multifetal pregnancy is increased in patients of PCOS who are being treated with injection HMG and HCG as ovulation trigger, because multiple mature ovum are getting released from the ovary in patients who are receiving injection HMG. So in those patients who are receiving injection HMG, multiple mature ovum can get released from the ovary and certain mature ovum can get fertilized, right? And they can result in conception. So the chances of multifetal pregnancy is increased in patients of infertility who are being treated with human menopausal gonadotropin. Now, what is the complication of human menopausal gonadotropin? It is an iatrogenic complication, right? The complication is happening because of the clinicians or the doctors, because of as only the problem is happening. So it is an iatrogenic complication. What is the iatrogenic complication of human menopausal gonadotropin, it is ovarian hyperstimulation syndrome. The ovary is getting hyperstimulated. If the ovary is going to get hyperstimulated, therefore multiple mature follicles which are going to grow, all these multiple follicles which are growing is going to get ruptured. And why this is going to happen is because I told you, in order to give the ovulation trigger injection HCG, the E2 estrogen level should be between 500 to 1500. But if the estrogen A2 level is more than 2500 picogram, if the estrogen estradiol E2 level is more than 2500 picogram, you should not give injection HCG. You have to withhold injection HCG. But iatrogenically, if you are going to administer injection HCG as ovulation trigger, despite the E2 level more than 2500 picogram, it is going to result in ovarian hyperstimulation syndrome, where all the follicles which are growing will start to rupture. Since it is getting ruptured, the VEGF factor is going to get released, and because this factor is getting released, it is going to increase the capillary permeability, and it is going to result in accumulation of the fluid in third spaces, right? Accumulation of the fluids in the third space is going to happen, and along with that, because of the capillary permeability, because of accumulation of fluid, there is going to be hemoconcentration, and because of hemoconcentration, there are increased chances of thrombosis as well. Is that clear, students? Ovarian hyperstimulation syndrome is a condition which happens if the estrogen level is not checked before giving injection HCG as ovulation trigger. If it is not checked, if the level is more than 2500 and injection HCG is given as ovulation trigger, all the follicles which are growing will start to rupture. And once it gets ruptured, the vascular endothelial growth factor, the VEGF factor, the vascular endothelial growth factor will get released, and it will result in increase in capillary permeability, and all the fluids will get leaked, and it will result in accumulation of fluids in the third spaces, and because of fluid loss, there will be hemoconcentration and increase in chances of thrombosis. So what are the complaints the patient will present to you? The major complaint will be nausea, vomiting, abdominal pain. This will be the complaint. What is the treatment in patients of ovarian hyperstimulation syndrome? The treatment is just conservative management. Administer IV fluids, give pain, analgesics for painkiller, that is analgesics painkiller for abdominal pain, treat the nausea, treat the vomiting, right? Treat the abdominal pain by administering analgesics, give IV fluids, and since there is increased chances of thrombosis in patients of ovarian hyperstimulation syndrome, you can administer heparin as a prophylactic measure. Administer heparin as a prophylactic measure since there is chances of thrombosis in patients of ovarian hyperstimulation syndrome. Right? So the most common iatrogenic complication of administering human menopausal gonadotropin is ovarian hyperstimulation syndrome. Right? So initially we gave letrozole or clomiphene. If that fails, the second line was injection HMG. If that is also not possible, then the third line of management is pulsatile GnRH. Pulsatile GnRH. So GnRH, if released in a pulsatile manner, it is going to release the FSH and LH from the anterior pituitary. It acts on the ovary, and the ovary will get hyperovulated, and the mature ovum will get released, and it will get fertilized, right? And it will result in conception, right? Yes. So this is the management of infertility in a patient of PCOS. Now, one important thing is that I need to show you the difference between ovarian hyperstimulation syndrome and necklace appearance of ovaries in patients of PCOS. So this particular image is asked in multiple competitive based examination, and many students are making a mistake. So now I will make it very clear now. See, in patients of PCOS, I told you, since it is similar to the appearance of necklace, it is called as necklace appearance on ultrasound. But this immature ovarian follicle might be present in the center, or it can be present in the periphery as well. And all these follicles are very small, right? They are very small. But in patients of ovarian hyperstimulation syndrome, since the ovary is hyperstimulated, all the ovarian follicles will be very large, and they will be diffusely situated, right? As you can see that it is having a diffuse appearance here in ultrasound. So, in PCOS as well as in ovarian hyperstimulation syndrome, the main difference is that in patients of PCOS, all these follicles are small and they are situated evenly in the periphery. But in ovarian hyperstimulation syndrome, the size of the ovarian follicle is big when compared to PCOS, necklace appearance, and all these ovarian follicles are situated diffusely in ultrasound. So they are diffuse in nature, one, and the second point is that they are very large when compared to the ovarian follicles in polycystic ovarian syndrome. Because in polycystic ovarian syndrome, all these follicles are getting arrested in growth because of increased androgen. So they are very small. But in patients of ovarian hyperstimulation syndrome, the ovary is getting hyperstimulated. So the ovarian follicle is going to be very big. So this is the major difference between ovarian hyperstimulation syndrome and necklace appearance of ovaries in patients of PCOS. So next time if you're going to get an MCQ, you have to mark it right. Is that clear? Yes. So now, the outdated treatment in PCOS. What is the outdated treatment in PCOS? That is laparoscopic ovarian drilling. Through laparoscope which is a magnifying instrument, we are going to insert the laparoscope through a port in the abdominal wall of the female, and through this laparoscope you are going to do ovarian drilling. What is ovarian drilling? Why this is actually done in patients of PCOS earlier? It is done in patients of PCOS earlier because the main problem in patients of PCOS is that increase in LH acts on the theca cells of the ovary to produce androgens. Because of that only there is increased androgens in patients of PCOS. And this theca cells is actually present in the stroma of the ovary. Like if this is the ovary, this is the stroma of the ovary. In the stroma of the ovary only the theca cell is getting present. Since the theca cells are situated in the stroma of the ovary, let's say for an example, if I'm going to destroy the stroma of the ovary, all the theca cells will get destroyed. Once the theca cell is going to get destroyed, then the increased amount of LH will never act on the theca cells to produce increased androgen. So therefore, the levels of androgen will decrease in patients, right? So for that reason, I'm going to do laparoscopic ovarian drilling was done earlier. So in this process, the theca cells are actually destroyed by burning the stroma of the ovary. So through the laparoscope, ovarian drilling is done. So ovarian drilling is where the stroma of the ovary is actually burnt. So since the stroma of the ovary is burnt, the theca cells are getting destroyed. So once the theca cells is getting destroyed, the LH, if it acts on the destroyed theca cells, it will never produce increased amount of androgen. So the levels of androgen is going to decrease. But the major problem at laparoscopic ovarian drilling is that if it is not done properly, it can lead to increased chances of ovarian failure. So ovarian failure can happen with the procedure of laparoscopic ovarian drilling, right? Yes. So this is one of the outdated treatment in patients of PCOS which is anymore not done. It is done, but it is done very rarely in certain centers. But now this procedure is not commonly done, so it is an outdated procedure, laparoscopic ovarian drilling. So once you get the term laparoscopic ovarian drilling, you have to remember theca cell destruction where the stroma of the ovary is getting burnt. Good. And with laparoscopic ovarian drilling, there is increased risk of ovarian failure. Right? Okay. Now, which is the most common drug which is going to cause ovarian hyperstimulation syndrome? The most common drug which we discussed earlier, yes, human menopausal gonadotropin, HMG. So the most common drug is HMG, and rarely ovarian hyperstimulation syndrome can be caused by clomiphene citrate as well. Clomiphene citrate can rarely cause ovarian hyperstimulation syndrome, but never letrozole can cause ovarian hyperstimulation syndrome. So letrozole can never cause ovarian hyperstimulation syndrome. Similarly, in procedures such as laparoscopic ovarian drilling can never result in ovarian hyperstimulation syndrome. The only problem with laparoscopic ovarian drilling is increased risk of the ovarian failure. So this is all about the PCOS that I have to discuss with you. Right, we made it very simple and concise for you so that this would be easy for you when you have to just revise in a period of about half an hour for your examination, right? So I hope that this topic is very interesting, right? Please keep revising and studying, right? If you have any queries, please write to us in the Mackler handle. We will write out to you as early as when possible, right? And please subscribe to YouTube Mackler handle so that you will get the daily